Welcome to the Philips Virtual HIMSS Learning Zone. I'm delighted to introduce our presentation, AI Economics, Evaluating Benefit for Hospital and Patient. And please join me in providing a warm welcome to our speaker for this session, Kevin Lev. Kevin is the Marketing Director for Advanced Visualization and AI Solutions for Philips. Kevin?
Thanks, Taylor, and thank you all for joining me on this presentation. We're happy to give an online presentation around AI economics and evaluating the benefit for both hospital and patient. The reason for why we thought about having a presentation on this topic is that when it comes to the world of AI, there's so much in terms of various different definitions that are out there. People define the world of AI in different, using different terms. People define how it is that AI is being implemented using different terms. And there's a lot of discrepancy in what people actually even mean when it comes to AI. And so, especially when it comes to trying to evaluate the economic benefit of these new technologies, and it's really a host of various different technologies, it almost seems like the Tower of Babel, of various different people talking various different languages, proposing benefits that might not necessarily be realized from one hospital to the next, or really finding a standardized way of being able to recognize the true potential of this new technology. So what we're going to try and do over the course of the next half hour or so is to propose ways that we can look at this world of AI a little bit differently and try and propose maybe a little bit more harmonization in the way that we approach the potential benefits of revolutionary technologies in this space. And we're going to do that from the lens of looking at it from the world of radiology. The reason for why is because if you take a look at the published data in the world of AI, particularly in clinical care, a lot of that published data, these are all reflections of scientific papers that have been published in common journals. And of course, we've gone quite a distance even from the year 2016. But you can see that still the bulk of publishing in AI and its effect on clinical care is in the world of diagnostic imaging. It's also a space that Philips excels in. So I think we're going to start looking at it from the lens of radiology informatics, from diagnostic imaging in particular. To do that, let's take a look at one particular example, a common example that you're going to see out there in the space of various different companies that all propose the benefits of what various different algorithms in AI can accomplish. This is one from Viz AI, common out there. All I did was basically take a screenshot of Viz AI's website, and you can see that amongst the top bar of the solution topics and solution headers that they have, ROI factors quite heavily in the benefits that they can offer as a company to their constituency. And this is an example that they bring as a case study, where they talk about if you happen to have 6 different spoke centers with a fairly high average volume of LVOs, it can actually drive towards a significant amount of potential revenue opportunity for that hospital. And this sounds great, and especially as a new hospital, this is the sort of data that I might be interested in when thinking about whether or not I use an algorithm like Viz AI or others when it comes to implementing that within my hospital site. However, results may vary, and this was an article that we came across actually just last month, taking a look at the use of artificial intelligence to identify LVOs, or large vessel occlusions, taking a look at a systematic review of how these algorithms are used. And you can actually see that there's a wide discrepancy in the usage of these algorithms in terms of the results that they're actually getting. So even in scholarly articles, what we're starting to see is that there's a need for getting much more of a standardization of performance assessment in order to be able to identify how we can implement these in various different hospitals. If one algorithm is going to give you vastly different results from another algorithm, there could be various different reasons as to why, but we need to have some harmonized view, especially looking at the economics behind it, if hospitals are going to know how to implement one algorithm relative to another, or one sort of AI relative to other AI within that hospital. So this is just taking a single example. To try and get a better sense of what we should be doing in this regard, I'd like to take a look at a recent paper that was published by Francois Cholet, taking a look a little bit more critically at the world of AI and trying to ascertain where we are with current AI algorithms that are used in clinical practice overall. And the way that he defines or takes a look at AI is that really AI should be something that allows for some adoption, some means of being able to change itself given various different scenarios that it encounters. So if you're looking at rainforest or a mountain or a desert, the way that algorithms should interact differently should be different relative in one setting relative to another. And that we generally find is not necessarily the case in a lot of AI that is currently being implemented in clinical practice today. I think we're getting to that direction, but still not quite there. So what he defines it is really narrow AI. And what that basically means is that it's AI that has been trained to recognize very, very specific scenarios, doesn't necessarily adapt as well as we might like it to at some point in the future. And therefore, what we should be doing is potentially evaluating it as no different than any other technology out there. Very often these applications and algorithms are black box, where we send data to them and they send data back to us, and they could be very smart and give us a lot of insight, but are not necessarily as adaptable. And if we're evaluating it just as we would any other technology, then it should adhere to the same principles of economics as any other healthcare technology out there. So what I tried to do is go back actually and take a look at one of the oldest economics books that I have on health and healthcare, and take a look at how it is the technology might be adopted out there. And one of the principles that we normally have in economics is that people make rational choices, right? That's typically the way that we start out a lot of economics. The problem is that when we take a look at healthcare, traditionally, economic theory provides us a very limited toolkit for evaluating choices that are made within healthcare, because very often people make decisions in not necessarily the most rational way, particularly when it comes to healthcare, and particularly when it comes to healthcare using new technology. And actually, behavioral economics plays much more at play than the standard rules of economics would. And actually, if you take a look at a lot of different adoption models that have been published in terms of how AI can or should be adopted into typical clinical practice, what you normally see is that these models are very behavioral in nature. Essentially what they are looking at how people might react to new technology, not necessarily how it is that these technologies can provide hard and fast comparisons using very foundational principles of economics to evaluate how one algorithm could be implemented relative to another. So really, I think what we're going to try and do is take a look at how can we employ really some of these hardened economic principles and the principles of economics towards at least standardizing the discussion around AI within hospitals, particularly not necessarily for the clinical benefit, maybe more for the IT and operational benefit within hospitals. So, can we start looking at things around very standard metrics? So one way to take a look at this is to take a look at very core metrics that even we within Philips have looked at as measures for how effective new technology can be, or how effective technology should be within healthcare, and that's around the quadruple aim, where we're looking to improve the patient experience, look for improved outcomes, or improved staff experience, or reduction in overall cost of care. The issue with these metrics is that these metrics themselves are prone to a bit of a discussion, not necessarily being very well grounded in what are the actual core metrics or numbers that we should be looking at when trying to compare algorithms or hospitals against each other. And as long as we can find some means of being able to improve the patient experience and potentially quantify that, that's good enough. So what we really need to do is maybe look at something a little bit more concrete. And so various different organizations like the Centers for Medicare and Medicaid have started to really look a little bit more at statistics and hard numbers that we can look at for how it is that we can rate hospitals on this quadruple aim, looking at things like mortality rate and actually putting down percentages for how it is that we should evaluate hospitals numerically on their effectiveness in the implementation of technology. What you can see here is that actually the efficient use of medical imaging is only a small component of that, only at around 4%. Okay, so I think what we try to, the first thing we have to understand is people very much respond to incentives. What we need to be able to do is, also as an economic principle, what we really need to do is to try and take a look at hard and fast numbers and create the right incentives and create the right discussions around the adoption of AI. So to do that, let's first understand that really AI is basically an enabler. Okay, it basically enables taking a lot of data and being able to put it in context to the way that we can provide more value, either in our cell phones or how it is that we drive. And similarly, within the world of healthcare, AI is really just an enabler of, not to downplay it, but it is an enabler of the capabilities that the radiologists themselves are using day to day. And if that's the case, then essentially what we can do is start to evaluate AI as a standard economic principle, as what we call input or factor pricing. Okay, it's a very common usage or a very common construct in the way that we look at almost more intangible economic assets, things like rental of property. How do you evaluate rental property? And it shares a lot of the same factors, things like that it has a derived demand. There isn't a direct demand for AI, there are demands for the outcome. It's dependent on a lot of other factors like data inputs. Pricing and supply are not necessarily equal, and there isn't necessarily unit homogeneity. Okay, meaning that one algorithm is not necessarily as the other. So essentially what we're looking at is trying to look at how is it that you can price something like a hammer, right? A hammer is a tool. It allows for other things to happen. And there's a lot of economic theory around this topic. In fact, if you take a look at how this is looked at from things like Princeton University, there's lots of different algorithms that are out there that get incredibly complicated around how it is that we can take a look at factor pricing setup and how it can be used. So instead of looking at it from this degree of mathematics, I think it would help to at least break down the discussion into basic principles that we should be looking at for how it is that that AI should be used. So one goal and the key goal for trying to understand the value of a factor to a hospital is to understand the marginal utility. The issue in that is that really the radiologist and all the tools that the radiologists use is only one key component of a large group of input factors that can be used in order to be able to evaluate the benefit towards the patient and to the benefit of the hospital. Is one part of a very large chain of services that need to be provided in order to be able to provide healthcare for a patient. So what we need to do is to take a look at considerations, okay? And some of the considerations is taking a look at input factor pricing neglects technology change. And I think that we can't only look at factor pricing theory for understanding how AI can be implied, because the technology is changing at such a rate and at such a quick clip that it's hard to evaluate it using the principles of factor pricing. It also assumes a standard distribution of expected benefit, and we're not quite at the area or quite at the time when we're cognizant of what that benefit can be. Or it also it assumes that we can also estimate what the expected risk of the factor might be. And here too, I think we're much earlier on. So what I'd like to propose is that we take a look at the AI, the benefits to the AI to the patient in the hospital, looking at it from a slightly different area. Okay, and what we're going to do for the balance of the talk is to propose various different approaches towards the adoption of AI, and maybe some questions that the hospital should be proposing when they ask themselves the question of which AI should we be adopting. I'm not sure we'll get to all the answers, but at least we all know that asking the right questions is potentially the best place to get started. So if we take a look at it from the standpoint of a patient relative to the provision of the service provided, number one is to take a look at demand and supply. So if the patient is demander of the services that are provided by AI, and we can take a look at the radiologist as or the healthcare provider as being the ones who supply the benefits within for the patient overall. So, you know, very often if we take a look at the factors of demand, one of the key principles that we have to be cognizant of is that people make trade-offs. Okay, which means that people have to decide between the provision and investing in one component or one area of their what they could do to improve their health relative to the other. But you know, when it comes to the world of AI, and especially with algorithms that really look at a host of different patients, we can't necessarily look at one patient. We have to take a look at multitudes of patients that could all benefit from it. And we all know that a lot of the algorithms that we're looking at or that are being implemented into clinical practice are not ones that the patients themselves have a lot of deciding power over. There are ones that we're only beginning to see the potential incursion of insurances and how they might be paying for some of these things. And actually, those AI algorithms that have been a bit more successful have been able to talk to the value that would be valuable to insurance, but it's less directly related to what a patient can affect. And I think that's one of the key take-homes that we can derive from this analysis, is that deriving the patient benefit from AI is a lot more ephemeral. It's a lot harder to do at this stage in the game. So let's take a look potentially at the supply route. And here, really one of the key principles that we should be looking at is trying to determine whether or not the marginal benefit, okay, is there a little bit more benefit for employing AI, and can that overcome the marginal cost of implementing that same AI? And here too, I don't think that we can be looking at it directly from one individual provider. What we need to be looking at it is from the standpoint of health networks or hospitals, and is the entire service being able to be a little bit more efficient in how it is that we can deliver services using AI. So here, what I'd like to then do is try and break it down into two different areas. Number one is to take a look at hospital operations relative to giving maybe potential better clinical insight. And when it comes to hospital operations, what we're talking about is, should we invest in more gauze pads or more technology? And here, I think a lot of the questions are actually fairly well established. There's a lot of different metrics out there. Taking a look at hospital standard operations, we can use AI, for instance, to take a look at scheduling of the radiology suite. And here, I think that the trade-offs in terms of time savings or benefit to the operations are very, very well defined. We probably need fewer models to try and understand how those work out, because there's a direct cost to input function in that regard. The better question that we might be looking at is to take a look at the clinical insights that AI can give us. And here, I think it's a little bit harder to try and analyze what those would be. So what we're going to do in the next couple slides is potentially take a look at a couple of those and maybe better understand some of the economic questions, at least, that we should be asking ourselves when we think about which clinical AI algorithms we should be implementing into clinical practice. So I think the first thing that we should take a look at is to understand that whatever we're investing in has some degree of opportunity cost. Okay, so taking a look at our example from the beginning of the presentation, yes, it's true that we might be able to implement or be able to get potentially $5.2 million worth of added potential benefit for the hospital, but there's also a certain amount of opportunity cost associated with the implementation of AI. So the first proposition is that when we do understand whether or not we should be implementing AI, we should not only take a look at the benefits that the hospital would be incurring, but what is a holistic view of the overall cost. And to do that, what we should be looking at is the classic definition of value and how it's defined within healthcare, is to take a look at quality over cost. Okay, what is the added quality? And what are the additional costs that it would take to get there? Turns out that there's actually quite a bit of cost implemented in, or that can be recognized in the implementation of AI. It's not just what we pay for the actual algorithm itself, or pay on a per-click basis, but there's implementation, maintenance, training, compliance issues. There's also the potential for false positives. We've actually found that certain hospitals are actually spending more time because of the AI that has been implemented in the hospital, actually not necessarily saving them time. And that's what we actually see in terms of what has been termed the cost of diversion. Because of the fact that there's actually more technology thrown into the mix. The question is that diverting the radiologist's attention away from treatment when they now have to deal with a bit more information, potential for lesions that they might not have seen, which may or may not be clinically relevant, that they now have to adhere to. So the first proposal is to take a look, when we're thinking about AI, well beyond the cost of the actual algorithm itself, and look at a holistic view of the costs, and take a look at the entirety of what that might mean for the hospital. And when we're taking a look at the benefit for the hospital, maybe what we need to be taking a look at is not necessarily the amount of money saved, or more situational metrics that a hospital would employ, but let's try and actually bring that down to outcome quality. Let's make it standards based and take a look at something that can be compared between various different hospitals, whether we look at relative value units or dailies. These are things that actually can be compared much more easily across hospitals, relative to taking a look at hospitals whose case mix might differ significantly, or whose situation might differ significantly hospital to hospital, which would make it harder to determine if one hospital would get the same benefit out of employing even the same algorithm as another hospital. Turns out that actually a lot of key organizations like the AHRQ and the ACR are actually taking a look at what are these quality metrics within AI that we should be implementing, also moving in the direction of trying to standardize these metrics, standardize our approach to data. And that's why you can see even on the ACR website that they're looking at advocacy and economics as one of the key topics that's of importance to them, really trying to make their approach founded on the same economic principles that we should be trying to espouse broadly across various different hospitals. Another principle that I think we should be looking at least understanding, is that typically when we take a look at principles of economics, we make the assumption that markets are very competitive, that one provision of a particular product can be very comparable to another. And that's not necessarily the case within healthcare. Healthcare is not a perfectly competitive market. There can be various different changes or various different things that might differ between hospitals, between networks of hospitals, between IDNs and private hospitals. And therefore, when we're thinking about the implementing AI algorithms across different hospitals and whether or not we can expect to get the same benefits, maybe something that we should be doing is case mix indexing. Another factor that we've seen very often in healthcare economics books. Taking a look at my case mix relative to another hospital's case mix, can we get the same benefit because our case mix would be similar, or at least scale and figure out what the differences might be. Also doing things like factor scaling. Is my radiology department the same or larger or smaller than another radiology department? What are the imperatives within my radiology department or the technology in that space that might make my hospital different from other hospitals? And then try and scale for that when we're thinking about implementing AI. And taking a look at the scale analysis, what we should be looking is not only at a particular element within the workflow, but take a look more at departmental outcomes, taking a look at end-to-end workflows instead of one component within that space. Because of the fact that we're able to point out more LVOs doesn't necessarily mean that as a health system, we are becoming more efficient. And maybe what we need to be looking at is the overall impact of various different AI algorithms instead of one against the other, and how's our department faring overall. The next principle that I'd like to get to is around the recognition of opportunity cost. We mentioned this a little bit earlier on in the presentation, where we have to take a look at the fact that just because there's potential benefit in AI doesn't necessarily mean that there aren't additional costs associated with it. And what we need to be able to do is to take a look at, can we have achieved the same outcomes with investing in other things, maybe not necessarily AI. And don't get me wrong, I'm a very strong advocate that we invest in AI, but we have to be very clear when it comes to asking ourselves the questions of things like, could we have achieved the same outcomes by a different mean? And what we can see is very often taking a look at economic analyses where they draw what we call isoquant curves. Isoquant curves is looking at, can you achieve the same outcomes on the margin? Looking at a mix of goods and services that you could have otherwise achieved. So for example, can you achieve the same outcome and same throughput by investing in more radiology residents as opposed to another AI algorithm, and maybe that will make you better off. Or maybe it really is true that we can take a look at the investments in AI and that would save on the necessity of having additional staff. So we have to take a look at both technical efficiency, which is, what's the maximum output, and looking at the least cost. Here, this gets back to, can that 5.2 million extra give us additional input? And then if we can get it at a lower cost, that's great. But we also have to take a look at the allocation efficiency. Are we getting the right outcomes for the desired inputs that we're actually putting in? And maybe there's other ways to look at that. Interestingly, there's an article that was published at the end of January, just this year, taking a look at the economic benefit of AI. And I mentioned this here. I think this is a very interesting article that we should all look at, because more and more what we're starting to see is articles like this that are looking at the overall impact in AI and asking a lot of the same questions that I'm proposing here within this presentation. And here, what you can see, and just in terms of the conclusion, the abstract, is that Powell here is looking at asking the same questions. Can we compare differences between organizations? Can we take a look at cost effectiveness analyses and maybe recognize that they might not necessarily be generalizable because of differences in practice patterns, and try and propose ways that we might be able to start looking at these things in a more academic way, in a more way that would allow us to be able to compare between systems. And here too, just to give a little bit of an oversight, he too also takes in a holistic cost view, essentially proposing something similar to what I proposed earlier in this presentation, taking a look at overall the impact of not only the one-time costs, but the ongoing costs of AI. Every hospital might have a different hurdle rate for their net present value of the investments as well. And I think the take-home message here is to go back to one of the things I had mentioned earlier in the presentation. Let's take an overall impact, an overall cost allocation, instead of just looking at how much it might cost to purchase the AI algorithm. And also, one thing that we can also do, and Powell also suggests, is that we also test at scale, that we not only do a test of AI in a very limited departmental or just for a particular disease state, but what we should be doing is taking a look at the total amount of patients treated in a control group, and then take a look at does the AI lower costs for that total amount of patients treated, taking a look at the total amount of costs. Maybe some of the drawbacks of this approach is there might be some of the ethics of denied improvement. If we take a look at, where some patients might be selected to be part of a control group relative to others that were not providing a provision of care, and I'm sure there's ways around that. But also, I think one of the limitations of looking at this is that very often what we're seeing is that there could be a lot of implementation time for AI. And it's not just a one-time cost for AI, but it might scale over time. That said, I think the principle of taking a look at departmental outcomes, overall treatment for patients overall, and taking a look at the overall impact of AI is part of the take-home message overall. And I think what we're starting to see is more and more, a lot of people are asking these questions, and actually this is a textbook that has yet to be published, but is coming out during the course of 2020, taking a look very keenly at value-based radiology, starting to ask these foundational economic questions of, are we improving patients overall, but not necessarily looking at it from a patient-by-patient or cost savings perspective, but really employing core foundational principles of economics to how it is that we look at our radiology department. So stay tuned, because I'm sure we're going to hear a lot more around this as well. So let's try and recap a bit around our presentation. I think one of the key things is that whenever we take a look at any proposed ROI, whenever we're seeing any company out there talk about the potential benefits numerically of what their algorithm might bring, that very well may be true, but we have to recognize that there are potential limitations in terms of the scale. There are potential limitations in terms of differences between hospitals, and we have to be cognizant of those when we try and employ those same AI algorithms within our hospital overall. The second thing is what we should try and do is strive for standardized metrics of marginal utility of the AI factor cost. Okay, so we talked about AI as being an input factor. What we should try and do is try and not necessarily look at it as its own factor and look at it only from the standpoint of one cost relative to the benefit, but look at standardized metrics like dailies and RVUs so that it'll make it easier to look at one hospital relative to another, or one health institution relative to another, and how they're implementing that. The second thing is, another thing is that what we should try and do is, if we're implementing AI, try and test ourselves. What we should do is try and employ control factors for comparison. Do that scale analysis, do that input factor analysis, so that when we're trying to look at how an AI algorithm might work within our hospital, take a look at case mix and understand how our hospital might be different, and then employ those before we implement AI. And then also try and take a holistic overview of the cost. Okay, costs are not going to be the single one-time implementation cost of AI. They might have a lot more other components associated with it, going as far back as taking a look at how data can be used and how we employ that data even to train AI, which is a whole other topic that we can also talk of. And then recognize that there are always trade-offs. Recognize that there's always the opportunity to be able to make investments either in AI or in other capabilities that we should. And with this, I hope what we should be doing is taking a much more harmonized view around AI, hopefully one that's more grounded in economic principles and the principles that allow us to be able to do comparisons between healthcare organizations. And I really hope that we continue to invest in AI because it has a tremendous amount of potential for the future, but do it in a way that allows us to have a standardized conversation that allows for commonality between hospitals rather than to point out those differences between healthcare institutions. So thank you. I'm very excited by the potential prospects we have in AI, the potential economic benefits, and look forward to where the future might take us.
Thank you, Kevin. To see more Philips Virtual HIMSS Learning Zone presentations, please visit the Philips HIMSS 2020 homepage.